Dr. Leckman, Brazilian scientists have a big research experience in the relationship between immunity to streptococcus and rheumatic fever. And you took part in a research that suggests that an immunological mechanism related to streptococcus. How can it influence the brain development?
Well, thank you for the question. It's a real honor and a pleasure to be here. It's interesting, I guess, in coming to this particular session, I think of Dr. Marcos Mercadante, and some of the work that he did initially actually had to do with this question. And we know that there are forms of autoimmune conditions that are post-streptococcal. So you have an infection, and as the body responds to the infection, it creates antibodies that are directed against the bacterium, and it turns out that some of those antibodies likely can have an effect on a variety of functions, including brain function. So what we know the most about is rheumatic fever, which is again a post-infectious autoimmune condition. And interestingly, some of the late manifestations of rheumatic fever can include rheumatic carditis, where there are autoantibodies that are actually cross-reactive with some of the proteins that are important in the heart, and you can develop all sorts of very serious medical problems having to do with the autoimmunity and the effects on the heart. The other one is something called Sydenham's chorea. Chorea is a word that refers to dance-like movements, and it turns out that this can also be a late manifestation of rheumatic fever. Interestingly, one of the first articles that Marcos wrote that I was a co-author on actually looked at the occurrence in rheumatic fever, and in particular Sydenham's chorea, of the presence of obsessive-compulsive symptoms, but also the presence of tic behaviors. And this was one of the first reports about tic behaviors, vocal tic behaviors, being present in the manifestation of Sydenham's chorea as one of the many different disturbances that could be seen. So this has led to a whole area of science, and I must say it's quite controversial in the United States. There was a concept that was developed probably 20 years ago by Sue Sweeto at the National Institutes of Health called PANDAS, Pediatric Autoimmune Neuropsychiatric Disorders Associated with Strep. And the criteria that she proposed at that time had to do with the acute onset of obsessive-compulsive symptoms or the acute onset of tic behaviors, as well as some other associated neuropsychiatric problems. And she proposed that these were in fact post-streptococcal phenomenon, very similar in some respects, although the actual autoimmunity might be different in terms of what the antibodies are, to something like Sydenham's chorea. So we've done a whole bunch of studies, and interestingly, some of them are very positive and some of them are very negative, that we have done. But it's also interesting, we're currently working with Sue in doing an immunomodulatory treatment of PANDAS cases to try and replicate the study that she reported first in The Lancet in 1999. And I think one of the reasons that we're involved is that we're seen as having some degree of equipoise. She has a vested interest in finding the results that she's hoping to find, but it's not entirely clear that that will be the result that we see. So we're actually doing the clinical ratings blindly to whether or not they're receiving the intravenous gamma globulin. But just to fill out the story, there are several other aspects to this that I find remarkably interesting. In our work on Tourette syndrome, because in the original formulation of pandas, it could either have been the acute onset of tics or the acute onset of obsessive-compulsive disorder. I have now done 3 studies, mostly with Tourette patients, and looking longitudinally, month after month after month after month after month after month, and drawing blood and doing cultures and looking very, very determinedly at whether or not a new streptococcal infection has occurred in these children. And I would have to say that those studies, for the most part, are negative. So here is a new, well-established streptococcal infection, and is there an exacerbation? Is there a sudden worsening of the tic symptoms? In the study that we just reported earlier this year, every single one of the exacerbations occurred in the non-pandas cases following a streptococcal infection. That being said, in the Tourette story, in the postmortem brain studies that we're doing, in the peripheral blood studies that we're doing, the immune system comes up over and over and over again. So I'm convinced that as we understand these conditions better, the immune system will play a critically important role in normal brain development. And there are all sorts of stories I could tell you about microglia and about some of the other compounds and cells that occupy the brain that are involved in the immune system, but probably are also involved in normal development as well. So this is a very long answer to your question, but I think it's controversial. And interestingly, last year, Sue and I organized a meeting at the National Institutes of Health where we invited all of the figures who were pro-pandas, anti-pandas, families who had children with pandas, and we got together to discuss how to move science forward. And several things happened, one of which was we decided to, can we agree on what the clinical syndrome is? And if we can agree on what the clinical syndrome is, then we can all study it, and we can look at what the causal mechanisms might be. But let's not confound our science just yet with this streptococcal connection being of necessity. So we came up with a concept called PANS, so I apologize for the acronyms, but PANS stands for Pediatric Acute Onset Neuropsychiatric Syndrome. And partly because of our studies, now it is just the overnight onset of OCD and other forms of, that's the primary criterion, overnight onset, sudden onset. And the tic story is there, but it's more of an associated symptom, so you need to have, depending on who you're talking to, 2 or 3 additional symptoms that also occur at the same time. Oftentimes it's acute anxiety, separation worries, change, a regression in behavior, a loss of handwriting skills. I mean, there are a whole range of things. Some of them are very unusual, things like needing to urinate over and over and over again, even though you don't really have a need to urinate. You have this urge to urinate. So there's some very peculiar symptoms, and some of them have also mydriasis. They have dilated pupils. So all of these things we're looking at closely in this clinical trial that we're currently doing with Sue. So there's an immune story there. The other piece is that we're working with wonderful basic scientists. So there's a wonderful woman, Madeline Cunningham, who works in Oklahoma City, and she's been working with Sue and now working with us, and she identified some of the autoantibodies that are involved in rheumatic carditis. And now she's identified in some of the pandas cases autoantibodies directed against what? Well, interestingly, some surface proteins on cells that are involved in, eventually, dopamine synthesis. Interestingly, some autoantibodies directed against the D2 dopamine receptors in the brain, also against the D1 dopamine receptors in the brain. So what's wonderful about this, if it's replicated, extended, and found to be true, is that it brings together some of the ingredients that we have always imagined to be true in things like movement disorders or Tourette syndrome, in terms of having more dopamine than you'd ever want to have. So one of the findings is that there is an induction of, and I apologize, of an enzyme called CAM kinase 2, and more CAM kinase 2 means that there's going to be more dopamine produced and released. So if this really is a functional mechanism, it really gives us some deeper insights in terms of what's actually going on. So we're measuring all of these biomarkers. We're also looking in the cerebral spinal fluid. We're doing very extensive studies with these children. And the other thing that we've done differently with this clinical trial is that it has to be the first onset. So some of these are young children, or the very first exacerbation. So we have conference calls and video conferencing with Sue's team every week to review cases. We're the ones that are screening all of them across the country, and they fly them into Bethesda for a more thorough evaluation if we think it's a PANDAS case.
And is it possible that in places or settings where rheumatic fever is more frequent, the kids will have more frequently brain development disorders, or these cross-cultural comparisons can give us more idea what is going on? Really?
Yeah, so we've done some studies here in Brazil. There are other groups in addition to Marcos that was involved in looking at the PANDAS question. We've done some work in Turkey and in Egypt where the streptococcal bacteria and these infections are more commonplace. It's interesting, in prior generations in the United States, so for example, my mother had rheumatic fever. My mother had rheumatic carditis. She had a problem with her heart as a result of this difficulty. But it's also very interesting. Not every streptococcal bacterium is the same. Different strains can produce different autoantibodies. And so it's very complicated. And so you might see an outburst of Sydenham's chorea, but that would be a particular strain in a particular geographic location. So it's quite complex in terms of, the other thing to know about streptococcal bacteria, if we're talking about that, is for the group A, beta hemolytic streptococcal bugs, where do they live? The only place they live is in the human body. They are our companions in life, and they are struggling to find a way to stay put and to continue to have the host that they need. But there is this sort of arms race between us. Well, let's see if we can get rid of them. But sometimes when we really try to get rid of them, we actually create more problems for ourselves with the creation of these autoantibodies. I'm not sure I answered your question, though. So talk to Eurípedes Miguel, and to talk to Guilherme, and they will answer all of your questions. That's what's important for them to know.
And knowing this relationship, what are the implications for treatment? Is it possible that we will have a vaccine, for example, that would prevent the development of OCD or tics?
Well, I think that we are still very ignorant. We're still pretty far away from that. The whole issue of vaccines means that you have to have a vaccine that will work against all of the strains of streptococcal bacterium, and that is a big challenge. People have been trying to develop a vaccine for streptococcal infections for a very long time, and we have yet to succeed. But some of the people we're collaborating with, there's a group in Minnesota, have been very active in that effort. But let's find out, let's see if we can really confirm that there is an entity like PANDAS, and let's study it and let's find out what the causes are. But it's quite remarkable to have somebody change overnight from not having OCD to having OCD. That is pretty remarkable, and I'm convinced that it happens.
Moving now to another field which is very exciting and interesting for us. In 1999, you were one of the first scientists to envisage the relationship between oxytocin and autism. And you have recently presented a work in Brazil about the use of oxytocin to people with autism. Currently, is there any research about the use of oxytocin as a treatment for autism. Could you tell us a little bit about this?
There's a lot of excitement in the scientific world and in the community of individuals who are personally affected with autism. But I would have to say, as in many areas of science, we have to be cautious. We don't know for sure, but it seems that it probably will be safe with a few exceptions, the exception being since oxytocin is critically involved in uterine contractions and milk release, I'm not sure you want to be giving it to women who might be pregnant. But from the experience that we've had, the experience that the group at NIH who've been using it have had, from the experience of people that we've talked to at Mount Sinai and what they have experienced, and what's been reported in the literature, so far we haven't seen any side effects whatsoever. And what's so fascinating, and this is not our work, but some work that was done in Australia and in France, they have taken people with high-functioning autism, Asperger's syndrome, autism spectrum conditions, and given them intranasal oxytocin in a double-blind way, and what have they seen? They've seen that, at least in response to static images of the eyes, that there's more attention to what is the emotion that's present, and a better ability to actually identify what the nature of the emotion is. They look more at the eyes, and they're able to identify emotional phenomena. Another, although I may be going on too long, I apologize, but another one of the interesting findings, and this is from Lyon in France, was they did double-blind administration, and they had them playing a virtual game. You could either throw a ball to a virtual person who would always throw it back to you, or you could throw it to a virtual person who would only throw it back to you maybe a third of the time, or you could throw it to a virtual person who would never throw it back to you. A person who doesn't have the autism spectrum would throw it randomly to the three different potential people, the virtual people. And the typically developing person would usually throw it to the person who would throw it back. After the oxytocin, again double-blind, the individuals with autism spectrum were more likely to throw it to the person who would throw it back to them. So I think that what's going to happen, and in the study that we're doing with Kevin Pelfrey, Ilanit Gordon, and some of our colleagues in Israel, Ruth Feldman in particular, is we're measuring peripheral levels of oxytocin, and we're also engaged in brain imaging studies and some of these similar kinds of social cognitive functions to see what the effects of the oxytocin are. One of the ones that Kevin is very interested in is something called biological motion. And this is where you outfit somebody with a bunch of little lights, and you can actually see them moving. And for people who are typically developing, it's very easy for you to tell that this is a person. It turns out that it's a little harder for somebody who has a autism spectrum condition to identify that clearly as a person. So Kevin's very interested. He has a certain area in the brain, the superior temporal gyrus, that he's particularly focused on. But it's fascinating. Oxytocin is also an anxiolytic, and many people who have autism spectrum conditions will report levels of anxiety, particularly when they're engaged in some social situation. So there may be a way in which the anxiolytic effects in and of themselves will be of real benefit. But I think time will tell. I think it's safe. A very similar compound, arginine vasopressin, is regularly used to treat enuresis, but they're virtually the same molecule, 9 amino acids. It's virtually the same. But I need to stop.
Even in children, so adults and children.
So we're doing it, most of the studies were done in adolescents and adults. We're doing it now in children. But we're down to, I think, 6 years of age, mostly because it's going to be harder to image kids that are younger than that in the scanner, and that's one of the things that Kevin's quite interested in.
So these results are really exciting. It's
Well, I think the fact that there is somebody who hasn't paid attention to social stimuli that well can change with just a few sniffs is pretty remarkable. Whether that will have enduring benefit, whether it will turn out to be something that can be synergistically used in some of the other treatment paradigms that help a person learn how to be attentive and respond to social stimuli, remains to be seen. But I think it is exciting, and it's quite remarkable. And it is true that years and years and years ago, Tom Insel and I wrote a paper, what does oxytocin have to do with autism? It's true.
And what do you think we need to have the oxytocin in the clinical?
I would say we need to have clinical trials, randomized, double-blind. Let's do it right. Even though it's safe, let's convince ourselves that it's true. One of the things that I've learned as a scientist is that if you give me a certain number of facts, I can make up a story that has really good scientific evidence behind it. But that doesn't mean that it's true until I test it. And we need to be open-minded about this. There's a great need. This is very promising. The literature on oxytocin is going up like that. But let's be conservative about it. Let's not go overboard just yet.
So oxytocin as a single treatment would not be
It might be. Let's find out.
Currently, this would not be indicated. I mean,
we don't have double-blind clinical trial evidence-based data that would say yes. All we know is that single-dose studies have this result. Now, if I wanted to be more conservative, I would say, well, if you look really closely at that study that was done in Australia, they did better. You know, it was measurably better. It was significantly better in detecting facial features associated with more common forms of affect. The more complex affects, they didn't do that much better on. And then if you ask yourself to put yourself in that situation, one of the issues that comes to my mind is just because you're able to look in the eyes, just because you're able to read the emotions in a static image, does that mean you're going to be able to do it in real time? I mean, whatever else is true, our facial expressions are always changing. We're always reading what the emotions are of the other all of the time. And is it going to help us keep up with that steady pace or not? But for many people, what that argues for is, well, let's try it at an even earlier age. But for us to do that, we have to make sure it's safe first in older children.
And there are any other ways that oxytocin can be released physiologically in the body instead of being given intranasal, for example, like massage or physical contact, or?
Yeah, well, it's fascinating. It's fascinating. So one of Ruth's studies, I think it's been published in an abstract, but we've been studying oxytocin in normal development, in parent bonding with their children. We've been studying it in romantic attachments. And this particular study, intranasal oxytocin were given to new fathers. So Guilherme's about to become a new father again. And interestingly, we measured the oxytocin in the periphery, and it went soaring up in the father. But what about the infant? Because we can measure it in the saliva. Even though that infant wasn't around when the dad sniffed the oxytocin, their oxytocin level went into the stratosphere. 30 minutes, within 30 minutes. So there was something about the interaction with this father. So I'm sure it's not a question on your paper, and I apologize, but some of the very interesting things. So oxytocin in the periphery can be released from other places in the body, including the gut and the heart and other places, the immune system. But interestingly, what it's correlated with in terms of maternal behavior is different than what it's correlated with regard to paternal father behavior. So again, this is not one of your questions, but interestingly, for mothers, it's sort of sensitive parenting and sort of how responsive is the mother in terms of dyadic interactions, and oh, look at how cute you are, sort of the use of motherese and sort of this sort of whole synchrony piece that Ruth and others have written a great deal about. But for fathers, it has more to do with stimulatory play. So the higher the level of the father's peripheral oxytocin, the more stimulatory play you would see with the fathers, and this is characteristic of fathers. I don't know if you did this with Gustavo or not, but throwing them up in the air and things of that sort. The more they do that, the higher their oxytocin level is. Sorry, I got distracted.
You mentioned that people with autism frequently has anxiety symptoms, and they also frequently has OCD symptoms. And is there any correlation, or how this relationship happens?
Well, it's interesting. Injecting oxytocin into the amygdala of rats can produce a obsessive-compulsive-like syndrome. What's going on? How can we understand this? One of the ingredients that we don't have a clear understanding of is the distribution of oxytocin receptors. And it may be that if we had a deeper understanding of what was going on with that in OCD and in autism, we might have a clearer picture of why we see these common phenotypes and differences and the rest of it. But it's an interesting question, but I think we don't really understand. We don't really understand. I think that, and interestingly, if you look up oxytocin on Medline these days, you will find that it's involved in GI tract functioning. You'll find that it's involved in muscular function. You'll find that it's involved in heart function. You'll realize that it's involved in immune function. And so it is one of these systems in the body that has an impact across many frontiers. And how that's going to play itself out over time, I think, remains to be seen. But it's truly remarkable.
Regarding the causes of autism and OCD, are there common pathways? Are there common causes between these two disorders, since there is a significant overlap between them in terms of presentation of symptoms?
I would say that the hypothesis would be yes. If you asked me to prove that to you with hard scientific data, I would say not so sure that I can really do that. We've been looking for the genes. Our hope was years ago that with Donald Cohen and with other people that we would find something like Huntington's chorea, that there would be a single gene that's responsible. And we've been fortunate to find a few genes that are associated in rare families with Tourette syndrome, some of whom also have autism and also OCD spectrum. But I think the etiology question is going to be a very complex one, and not one that is likely, typically going to be one where there's a single gene involved. There may be a double hit. There are all these sort of rare variants. There are these copy number variations. I mean, it's quite remarkable. So one of the things that we're doing now, which I think is a way forward, is to actually look at brain tissue and to have an opportunity to see what genes are expressed in the brain of individuals with this condition, that condition. Now, obviously, that's not something you can do with your patients, because they're still alive and you want to keep them alive as long as you can and to have the best life that they possibly can. So one of the other things that's now possible is stem cells. And there's been a huge ethical controversy about the use of stem cells, because up until just a few years ago, the only way we could get them was actually to take them from fetuses or from stillborns. Now you can take just a piece of skin and you can actually create in the laboratory, and that's being done here in São Paulo, to actually have neural cultures, neural stem cells. And here the work is being focused on dopamine cells. We're actually doing work with regard to another class of neurons in the striatum, some of the interneurons. But it would be fascinating to look at the oxytocin cells or some of the other systems that are present in the brain and what regulates those developmental pathways.
So the idea would be to look what genes are being expressed by these neurons, and this would help us to identify the genes that are related to...
Yes, but I think the other thing that you'd be very interested in knowing about is what is their developmental course. So if you had 3 cultures of Guilherme's neurons, do they, in a consistent way, follow a particular developmental progression? And how is that different than for someone whose skin cells were taken and they're individuals that are on the high-functioning end of the autism spectrum, or something like that?
So the timing where the genes are turned on or turned off would be relevant.
Yes. So I'm quite excited about that, to have actual patient-specific neural cultures, but it's expensive. We don't really know whether it's going to answer any of our questions. And just recently, in looking at the transcriptome data from the brain tissue, I'm actually a little more excited about that in terms of leading down a path. So, for example, in the Tourette's, although I shouldn't say anything about it because it hasn't been published and it's a small number of studies, the immune system is all over the place. In the basal ganglia of these people who died with very severe Tourette syndrome, the immune system is differentially active compared to the typical brains that we found.
And moving a little bit to the clinical picture, in children and adults with autism and OCD symptoms and obsessive-compulsive symptoms, treating these symptoms, these OCD symptoms, is as efficacious as in children or adults without autism. So the treatment of OCD symptoms is moderated by the autism.
Well, interestingly, many of the individuals with autism who have significant obsessive-compulsive symptoms, especially if they're on the higher end in terms of cognitive function, can learn rules really well. And if they're motivated to actually take on some of the cognitive behavioral interventions, they can be very good at it. They can be some of our best responders. But I would have to say, I think it's an open question about some of the other interventions. Interestingly, a lot of these individuals also have tics, and oftentimes they don't respond quite as well to the SSRIs than they do when you sometimes will augment that with other medications. So, it's a complex story. We need to find new treatments. We need to find better ways of helping the families and the individuals with these conditions. And I'm convinced that the group here in São Paulo is, just like Marcos Morcadenche and others, are doing everything they can, whether it's animal models or whatever it is, to try and move forward in terms of the scientific enterprise.
And talking about new treatments, and we usually listen in the media about diets, specific diets, removing or replacing. Is there anything that the science can tell us about?
Well, I think, again, we need to study that carefully. I think the fact that we have done such a poor job in providing good treatments means that people will turn to whatever they can possibly find. And today, in the Internet world, there are all sorts of options that are out there. So my only issue would be, if you found it helpful, let me know, but we need to study it scientifically before I would be convinced that it's a way to go. One of our colleagues, Michael Block, who I think you've met, has been doing one meta-analysis after another. And interestingly, we've had some positive results with some of the complementary medications like omega-3 fatty acids for things, a modest effect with regard to ADHD symptoms. The higher the EPA level being administered, the better. But other things like DHA in formula, we're finding absolutely no benefit from looking at all of the studies that have been done. So I think that it's hard to generalize, but I would say let's see if we can move forward and move ahead with the science. It's good to be optimistic and positive in our thinking, and we need to try new things, but let's wait to say for sure until we've actually got good, hard scientific data.
Thank you very much for
welcome.
thoughts.
Thank you.